The next category that we're going to jump into is stroke. And when we look at stroke, this is an acute brain attack or a cerebrovascular accident, a CVA, acute brain attack or cerebrovascular accident. So when this happens, it ends up being a decrease in perfusion to the brain that leads to cellular damage and cellular death. So whether it's an infarction will lead to death. If it's a ischemia, it will lead to cellular damage. So we just need to make sure that we kind of differentiate those two terms right now. So when we look at the two different types, there's a hemorrhagic stroke and there is an ischemic stroke. So when we look at the ischemic stroke, these 80% are going to result from a thrombus or an embolism. So remember when we talked about pulmonary embolisms or pulmonary emboli, a blood clot that breaks loose and ends up in the brain, we called it a stroke. A blood clot that breaks loose and ends up in a coronary artery, we called that a myocardial infarction. A blood clot that breaks loose and ends up in the lungs, we called that a pulmonary embolism. Again, these blood clots can end up breaking loose from their deep vein thrombosis and navigate to different parts of the body, causing havoc everywhere. When we look at hemorrhagic stroke, this is actually 20% of the cases where you actually have a subarachnoid hemorrhage or an intracranial hemorrhage, which is actually a brain bleed. And when we talk about stroke, this is actually the 5th leading cause of death in the United States. Stroke is the leading cause of long-term disability and results in billions of dollars in healthcare spending every year. When we talk about specific risk factors, we talk about hypertension, diabetes mellitus, tobacco use, excessive cholesterol, peripheral artery disease, and atrial fibrillation. This joker has shown up in a couple of our disorders here recently, and we need to make sure that when we see AFib, we know that it's an increased risk for so many other things. How many times have you seen hypertension or diabetes mellitus on your patient's charts? What can we do to help educate our patients about tobacco use? It's going to create and cause and expose your patients to all kinds of toxins that leads to this thickening of the blood or polycythemia, which can cause an increased risk for stroke. And cholesterol, we know that there's a good cholesterol and a bad cholesterol, your LDL and your HDL, but we'll talk about those in a later lesson. And then anybody that has peripheral arterial disease or peripheral vascular disease for that matter, these patients are at risk for thrombus or thrombi that can break loose and then travel to a different part of the body that we don't want to see happen. When we look at the clinical manifestations of strokes, they're typically related to the location of the insult and the degree of ischemia. The onset of the symptoms are typically acute, and patients may report a history of TIAs or transischemic attacks with temporary neurologic symptoms in the weeks to months preceding an acute stroke. So these patients are exhibiting symptoms, and we call those symptoms TIAs or transischemic attacks. These are symptoms that are showing up before they have a full-blown attack or a full-blown stroke. When we look at the patient's vital signs, they're going to have an increase in blood pressure. We already talked about that with hypertension. They're going to have a decrease in respiratory rate, and they can even have a fever. The decrease in respiratory rate is because of an increase in intracranial pressure, and we'll talk about that when we get into our head injuries talk. But for now, just understand that there's going to be an increase in blood pressure, an increase in intracranial pressure, which will decrease your respiratory rate, and an increase in fever or facial extremity muscle weakness. You'll have sensory, visual, or cognitive impairment, contralateral lower face weakness, ataxia, speech impairment, and visual difficulties. So when we talk about the location, we've got to understand where the stroke took place. Does it happen in the midbrain? Does it happen anteriorly? Or does it happen posteriorly? Or you could have strokes that are in multiple areas. When we have those, we need to make sure that we are on top of our game as well, because the signs and symptoms are going to be variable. But when we have middle brain, you're going to have that contralateral sensory motor impairment, the contralateral lower face weakness, meaning the opposite side is contralateral, the opposite side. So if you have a stroke in your midbrain on the right side, it's going to impact your left side. This patient's going to have speech impairment, whether it's a slurred speech, they're going to have blurred vision. Those are all impacts of a middle brain stroke. These posterior strokes are going to present with contralateral hemiplegia. Again, the opposite side is going to be paralyzed. They could have some chorea. They could have visual field deficits. They could have memory deficits. They could have visual hallucinations. It just kind of depends on the symptoms and presentation of the stroke. If we've got an anterior stroke, this is going to lead to motor impairment of the lower extremities, and these patients could have incontinence or they soil themselves. So lots of different impacts or clinical presentations depending on where the location of the stroke is. Complications that are associated with an acute central nervous system injury can result in acute pulmonary edema. They can impact with tachycardia, tachypnea. Again, pulmonary edema, you have that complete alveolar consolidation. How well is that patient going to diffuse oxygen from the alveoli into the pulmonary capillaries? They're going to be hypoxemic. Hypoxemia, breathe more, beat more. Tachycardia, tachypnea, it makes sense. They're going to have a decreased level of consciousness. I'm not getting blood to areas of my brain. It's not going to work the way it's supposed to. You could have an impaired cough or an impaired cough reflex, meaning I'm trying to stimulate that patient with a Yonker or a suction catheter or what have you, and they cannot cough. Well, if they can't cough, they can't protect their own airway. If they can't protect their airway, that's going to lead to an increased risk of aspiration. Aspiration can lead to pneumonia. If you have aspiration pneumonia, where is most likely that pneumonia going to end up? The right middle lobe. That's right. So when we look at the last complication that's associated with strokes, and all of these signs and symptoms with the impaired cough reflex, inability to protect their airway, aspiration, and pneumonia, comes from this oropharyngeal dysphagia, which is an inability to protect your airway. And that comes hand in hand with this decreased level of consciousness. So what else might we see when it comes to these stroke patients? Well, they're going to have periods of apnea, whether it's obstructive or central sleep apnea. They are going to have potentially periods of apnea. Cheyne-Stokes respiration, that comes hand in hand with our central sleep apnea. Anytime that there's brain involvement, you could have BIATS or apneustic breathing, and you could have this patient that becomes hypoglycemic. When they're hypoglycemic, they're going to want to hyperventilate and have Kussmaul's breathing to blow off as much CO2 as possible, because they are gaining a ton of fixed acids when it comes to the ketoacidosis. So remember, when we look at causes of metabolic acidosis, I want to know if it's a GAP or a non-GAP. If I look at the GAP versus non-GAP, I'm going to use two different mnemonics to identify if it's a GAP acidosis or a non-GAP acidosis. If it's a non-GAP acidosis, this is a true loss of base. This is a true loss of base, and I'm going to use the mnemonic SADRASH. If it is an increase in fixed acids, this is going to be a GAP acidosis. My GAP, my anion gap, is going to be greater than 16. And the causes of a GAP acidosis are mud piles. In mud piles, the D stands for DKA, and DKA presents with an increase in ketones. Those ketones cause hypoglycemia. You're going to blow off CO2 to compensate for this increase in fixed acids, leading to deep and fast breathing to eliminate as much CO2 as possible. And CO2 is an acid, so we can control our acid base or our pH by eliminating CO2 with our Kussmaul's respirations. So lots of different breathing patterns that are associated with stroke. Be sure that you're familiar with them. When we look at the diagnosis of a stroke, this is an emergent situation and you have to intervene immediately. Immediate intervention. The timeline is critical when it comes to these stroke patients. We have to restore blood flow. So we have to either alleviate the hemorrhage, or we have to alleviate the ischemia. Either one we have to take care of because we don't want this patient to have neurologic deficits. When we look at diagnostics, we're going to use a CT. This is going to be our key indicator for a stroke. We're going to get a CT with angio for a patient that is potentially a stroke patient. We could get an MRI that will show us details that are within the brain. These patients are going to end up on supplemental oxygen. We talked about an increase in intracranial pressure. Normal pressure is 5 to 10. When the intracranial pressure gets above 20, that is critical and we need to have an intervention. We'll get into those a whole lot more when we talk about head injuries, but just know those normal values right now because we will deep dive those in the future. When we look at management, these patients are going to end up with TPA, or tissue plasminogen activator, or TPA. This is a clot buster, and it breaks up or it lyses clots and reestablishes cerebral perfusion. We want to give this within 4.5 hours. I told you the timeline is critical. We want to give this within 4.5 hours, but we want to be mindful of any contraindications that that patient may have. These patients could end up in interventional radiology, where they can go in and have that thrombus removed by a skilled physician that could go in and take care of that. These patients end up on antiplatelet therapies, like aspirin is our most common one. These patients are going to be on antipyretics and cooling blankets because we do not want an increase in our metabolic demand or a big change in our CO2 or O2, because that will impact our cerebral perfusion. If you have a Glasgow Coma Scale or a GCS less than 8, again, we're going to jump into Glasgow Coma Scales in our head injuries, but if you have a GCS less than 8, that patient does not have the ability to protect their own airway and you need to intubate. GCS less than 8, intubate. You want to prevent hypoxemia and hypercarbia. Both of these two things will increase the intracranial pressure, which will worsen cerebral ischemia. We want to avoid these patients coughing or gagging. Again, you cough, it increases your ICP. An increased ICP increases cerebral ischemia. So things that we will do to make sure that we're taking care of them is bronchial hygiene. We want to make sure that these patients are ambulating. We can give atropine or even Botox as a vasoconstrictor sublingually below the tongue so that it will decrease the amount of saliva, and we want to reduce the amount of oral secretions that they could aspirate on. And depending on the cognition of that patient, if their GCS is greater than 8, we can use non-invasive ventilation, BiPAP, CPAP, or even those variable PAPs, the VPAP. We can use those to treat any patients that have sleep apnea or hypoventilation syndrome. The respiratory therapist should be aware of any abnormal breathing patterns that occur after any cerebral injury, especially Cheyne-Stokes respiration, so that we can get them on the appropriate ventilatory support that they need. So stroke, make sure that we are aware of strokes. This will come back when we go over ACLS, but it is definitely one that needs to be on our radar.